Dr. Danielle Calvis here to talk to you a little bit about pharmacogenetic testing labs and that also in the setting of diabetes. So since sequencing the human genome, great strides have been taken in the medical community to specifically tailor therapy for patients using their genes. The study of pharmacogenetics is the process in which a genetic test reveals a patient's sensitivity, absorption, metabolism, half-life, and response to a medication. This allows a healthcare provider to determine the optimal medication dose and frequency while decreasing the adverse drug reactions and toxicities, reduce morbidity and mortality rates, and cost. This also greatly reduces the amount of time it would normally take a patient to find a tolerable, efficacious drug combination. For example, in the setting of antidepressant medications, many patients cycle through upwards of 3 to 6 different medications, right, before finding one that really treats their symptoms. Each antidepressant should be taken for a minimum of 3 to 6 months before determining that the drug is either effective or not, or if the drug is actually not accounting for the potential negative side effects that a patient may endure. Pharmacogenetic testing, it's a mouthful. Pharmacogenetic testing reveals specifically which receptors will react the best to certain medications. So akin to testing if a bacteria is sensitive to a certain antibiotic. Patients have reported excellent results from these tests, and eventually such labs will become standard of care before prescribing medications. Some roadblocks do exist to widespread genotyping of patients. Although new research is emerging, it is neither ethical nor safe to administer medications to patients where it isn't warranted, limiting the cohort population sample to only those patients who need a particular medication and treatment. This makes studying the genotype of responses to medications difficult. Furthermore, studies have shown wide variability in genotyping, which equates to unreproducible results between patients. So all of that to say, even though a patient may test positive and be sensitive to a particular drug genetically, in real life, their actual response to the medication can vary significantly from patient to patient. So this makes the widespread recommendation to pharmacogenetic lab testing still a bit premature. But labs do exist to test for response to antidepressants, chemotherapy medications, and blood thinners, just to name a few. Scientists have identified and heavily studied the key liver enzymes responsible for metabolizing certain medications. Some patients are, quick metabolizers, meaning the drug is used, processed, and cleared quickly. In comparison to the general population, they may require higher or more frequent doses to have the same therapeutic effect. So this is akin to someone who can consume high quantities of alcohol, but rarely appear inebriated or hungover the next day. Because these studies are still in their infancy, routine lab work is still required, to monitor a patient's response to a drug. So eventually, the goal with pharmacogenetics will be to identify the correct dose and frequency of a medication with genotyping alone. And these results will be consistent in large populations of patients. So pharmacogenetic testing of diabetic medications has been underway for about the last 10 years, with the biggest emphasis being placed on just a few medications such as metformin, DDP4 inhibitors, GLP-1R agonists, the thiazolidinones, and the sulfonylureas. So to date, about 40 polymorphisms and 71 loci have been identified. Studies are currently still looking to better elucidate the medical decision-making approaches. So, how to take the genotyping information gleaned from patients and practically apply it in precise medicine strategies. So there exists a large gap between how to take the genetic information and safely apply it to patients. So large clinical studies need to be performed to accurately determine these medical decision-making pathways. Currently, as it stands right now, based on all of the guidelines and published research that I've been looking at over the last 2 years, it's currently unsafe, unethical, and not recommended to make clear-cut drug recommendations or changes based solely on pharmacogenetics in regard to diabetes. Despite widespread marketing and FDA support, the medical community is still in the experimental stages of this. I think within the next 5 to 10 years, it will totally be standard of care. However, many practitioners and clinicians are extremely slow to adopt pharmacogenetics. Older practitioners may not have received extensive training in genetics in their formative years, and this is still a relatively new field. Insurance companies will also have to adjust, which introduces the controversial idea that perhaps a patient's premium will be higher if they have certain genes, or maybe be denied coverage entirely.